Thank you again for this opportunity, and life is going to be easy for me because the comprehensive assessment has been covered, and I'm going to look at it from a slightly different point of view in terms of, are we doing a good job, good enough job, are we failing the kids that we are serving? I have no conflicts to declare except funding from National Health Medical Research Council and the Autism Cooperative Research Center. Now, another way of asking the same question is, are we doing a good job, are we failing, and where are we failing? I'll just give you an example of the mean age of diagnosis in Australia. We recently looked at the data and we found that it's 4 years. And if I were to ask that question, are we failing, I would say yes, because 4 years is really late. Because those kids are already starting kindergarten at the age of 4 and they have already missed out on that early intervention opportunity. And the missed opportunity is for the child, for the family, and also for the society, because the social educational resources are also, there is an impact on that. And there is a huge impact on the mental capital for the nation. Just because we are being delayed or failing to accurately identify them earlier on. And the question then is, why are we failing? What's the problem? Where is the problem? It's difficult to figure out. We did hear about sometimes the length to which we have to go to make an accurate diagnosis. But pretty much if you look at the social interactional difficulties, the communication issues, and the restricted repertoire of activities and interests, and you would say, yes, in most cases, we should be able to figure that out. Then is it to do with when these symptoms are emerging and the onset type? You could say that for about 13.6% or so, it's very, very early on. Parents would say right from the word go, we knew something was the matter. No social smile, no small bonding, etc. For some others, about, again, the same figure, 13.6%, they had gained skills and then they regressed. But for the majority, close to 70%, we are talking about that around 1 year of life, just after 1 year, I would say, and in the second year of life. So it mustn't be that difficult for us to keep our eyes open, our ears open, and look out for these kids. You could say that parents may optimistically disregard some of these symptoms when it's really mild, it's really emerging, but programs like the Universal Developmental Surveillance, like I mentioned yesterday, should be able to catch most of these kids, majority of kids. Again, is it the diagnostic criteria that we use that's the issue? Is it the tools that we use? It's the issue. Awareness is the issue. Is there a service gap issue? For example, only 1/3 of kids would come for clinical services. The others are in the community. So are we going out and accurately identifying them at the right time and giving them the opportunities that they deserve? That gives us the next question. Who seeks help? Who does come to the clinical attention of people? Maybe they are at the severe end of the spectrum, or maybe they have some complex issues like the comorbid epilepsy, or maybe they have got significant mental health issues, which is bringing them to the attention. But are we then having a good, thorough assessment which will give us the right diagnosis, including the comorbidities? I'll give you an example from a clinical case that I recently saw. It's a young person who is presenting with ADHD symptoms. Very clear teacher reports that the child can't sit still and there are significant issues with attention, concentration, no problems there. Almost a sport diagnosis, one could say. But the child is also, the parent says, fidgeting and twitching. And I explore a bit more about the twitching and the fidgeting. I come across a lot of motor tics, and I'm someone who would sniff out tics anywhere. And so I come across a lot of motor tics. And then there's a sniffing. That means that's a vocal tic there. And then again, on further history taking, I stumble upon a few more things. He has some social deficits. He has no friends. He is being bullied because of his old ways of communication and behaviors. Look at the family history. Paternal uncle is socially awkward. Dad had childhood tics. Paternal grandmother and aunt both have severe OCD. So potentially we could fail this child if we just get on with identifying the ADHD and just treating the ADHD. But if you look out for a comprehensive assessment along with comorbidities, you can also get a lot of clue about the clinical heterogeneity and what kind of symptoms, patterns are emerging for a particular individual. And that will also may be linked to genetic heterogeneity. For example, this child possibly could get a diagnosis of ADHD, Tourette syndrome, autism spectrum disorder, maybe also has got OCD, as it turned out later on. Is it all part of the same phenotypic presentation of the same underlying neurodevelopmental gene issue? Is the autism and the Tourette's related, unrelated comorbidity? Is the ADHD in the patient linked to autism? Is it linked to Tourette syndrome? Both? Neither? Is it shared by other members of the family? For example, the paternal uncle who is socially awkward, dad who had childhood tics, paternal aunt who had OCD. So it kind of then emerges a picture of a neurodevelopmental issue going on in the family and also related to the particular patient in front of you. I would say that neurodevelopmental genes haven't read the DSM criteria, and therefore they won't behave like you would expect them to behave. NEAT ADHD or NEAT ASD or NEAT Tourette syndrome or NEAT OCD. And they often come in packages. And those packages are for us to unravel and for us to then help the person with. And all clinicians, I'm sure, all good clinicians would have stumbled upon these cases when you are looking for something and then you find something else. And that's why we need to do a very comprehensive assessment of these young people as they present. And clinically, we may sometimes get just drawn to the most prominent or the most impairing symptom. But within that family and within that spectrum of issues that are presenting, it's extremely important that all the other aspects are also taken into consideration. So again, are we failing them at that point of care because we haven't done a comprehensive assessment? Are we missing the diagnosis because they come with very specific clinical features like high-functioning kids, or often people say they get missed. If they have better IQ, they may get missed. If they have better adaptive skills, they may get missed. And maybe some female phenotypes may get missed. And is it to do with the service organization, whether it is in the health sector or in the education sector? In Australia, in 2009, the HAQA package was brought in, which is helping children with autism package. Every child was entitled to receive 6,000 Australian dollars, which they could then access their chosen early intervention, and that would go on till until the age of 7 years. But then we all agitated, saying, how about kids who are right at the cusp or showing symptoms but sub-threshold? Do you really need to make a diagnosis to get that early intervention? Are we failing them? So when the National Disability Insurance Scheme came about, so the HAQA package is being phased out and the NDIS is being rolled out as we speak, and we suggested and they agreed that early intervention should not require a diagnosis. And probably if we hadn't done that, again, we would be failing a whole lot of kids who people would be very reluctant to give a diagnosis for the right reasons, but would have missed out totally. So what is the function of diagnosis? Why are we doing it? That is a very important question we need to contemplate. And I would say, let's take the breast cancer scenario. Would we wait until somebody gets a diagnosis of breast cancer before we provide them with services? Or we would go out and look for those with breast lump? So for definition of a case could differ based on what the function is. So in the community, if you are about early identification, a breast lump would be good enough as the starting point. But if you want further diagnostic classification based on the staging, maybe you would look at the pathology report. If you want to have specific treatment, then you may look for genetic profile, BRCA gene, whether it's present or not, when you consider treatment. So the function of what it is serving should dictate how we organize our thinking around those issues. So early identification, a breast lump approach, so everybody who has got any early signs and symptoms could get the benefit of further assessment and appropriate intervention. But in terms of educational support, maybe that's not the most relevant thing there. You may look for cognitive level, for the functional capacity, to determine what educational support they need. Again, the serving a function should dictate what you do and how you manage it. Again, the surveillance program like the mammogram, once you identify, then you can take on a hypertension approach. So you continue to monitor them as if you would do in hypertension. If the WHO were to change the diastolic blood pressure required to make a diagnosis from, let's say, changed from 80 to 81 overnight, many people would wake up in the morning without a diagnosis. But did anything change? Would it matter for your GP who is treating you? That's the kind of approach that we would take. So initially for the identification, we take the breast lump approach, but for ongoing monitoring, we probably need to take the hypertension approach. And in case of any syndromal diagnosis, that's probably right to say that it's not just one or the other. And I usually tell my medical students it's the 3 Ds. So significant deviation from delay or deviation from what is expected for the age and gender. Is it causing distress to the patient and the family? Is it causing significant dysfunction? So if those 3 Ds are there, then you could potentially be saying that justifies identification in the form of a diagnosis and appropriate intervention. And are we also able to do a categorical diagnosis within that dimensional approach, just like we would do in hypertension? And I'm sure nobody would argue if we were to say it's very important to take or identify people who are in the pre-diabetic stage or in the borderline hypertension range, because it's very important to have the lifestyle changes and other health promotion and preventative programs put into place. And so we don't necessarily have to change the definition and the criteria, but we as clinicians need to organize ourselves and our services with that kind of an approach of what is the function this particular assessment, this particular diagnosis is serving. And once we have that categorical diagnosis, we may still need to look out for subgroups within. And that subgroups may come from the behavioral profile, from the genetic profile, neurocognitive profile, and so on and so forth. And it's very important there we can follow a diabetes model. Diabetes is very clinically heterogeneous, genetically heterogeneous. We often would talk about type 1 and type 2, but also there is the maturity onset diabetes of the young, or MODY. You can subtype MODY again into 1, 2, and 3. But when you are communicating to the lay person or for an awareness campaign in the community, we just say diabetes. But when I'm communicating to another professional, I might say type 1 or type 2 or MODY. But if I'm doing a pharmacotherapy research using sulfonylureas, I may need to subtype again the MODY into those who have got HNF1A or HNF4 A mutation, because they respond better to sulfonylureas. So again, we do have those examples in medicine, whether it's the diabetes or the breast cancer or the hypertension. We live with that and we are very comfortable with that. And I guess what we need to do is to probably think about those kind of models when we are thinking about autism spectrum disorders and how we might organize our services. So there may be a lesson to be learned in that genotype to phenotype interaction. If 10 years ago, if people said breast cancer would be treated based on the genotype, we would have said probably not very impressed. But now the standard care is that. We could work towards that. We may not be there yet, but that's the way we should be progressing. And we also should be looking out for what would work for whom and why. And we do need to gather the evidence of those who are responding and equally those who are not responding. And what are the characteristics of those kids who are not responding would be equally important so that we can subgroup them, identify them early, and do things differently. So is it to do with the individual behavioral characteristics that they come with? Is it the type of the intervention or the dose of the intervention at the age at which the intervention is started? Whether it's the family and other psychosocial factors that's important? Is it the genetic profile that is important? Maybe a combination of all these things. But if you can learn from where breast cancer has gone and where diabetes has gone, maybe that's what we should be aiming towards. And so subgrouping based on genetic or neurocognitive profiles would be an important step. We are doing it in terms of understanding why some kids don't respond to early intervention in our center. And we looked at some of the social versus non-social stimuli, and the assumption being made is that we use the Early Start Denver model, which is a very much improving, fostering the social communication side of things, but maybe the wiring of the brain for some kids is very object-oriented, and they are not able or lighting up the right part of the brains to be able to utilize the type of intervention that we are giving. And again, there is a saying that in the Silicon Valley, there is a overrepresentation of the geek syndrome. So you give people who can get really stuck into the mechanics of things and be great nuclear physicists, or be more interested in how things work or the mechanical side of things than where's my break, where's my friend, when am I going out for dinner. So the social communicative brain may be quite different to an object-oriented brain in the way it's wired, and therefore maybe we have to have slightly different tweaking of interventions if we need to get them. So we did a bit of eye tracking and also the near-infrared spectroscopy. We used NIRS because you just have to put on a cap and it can be done in the naturalistic setting without having to do the various other things that's important for neuroimaging. So we presented a social stimulus. Here is somebody singing a nursery rhyme, and then we look at the brain activity pattern there, and we also then show them some object-oriented spinning toy thing, and we look at what the brain activity is showing. And again, the variability in outcomes to some extent could be attributed to the way they were responding to the different types of stimuli. Again, tells us that one size does not fit all, and the same is true for any syndromal diagnosis, because we are not really treating the specific etiology or the pathophysiology. And that's the case with headache too. At one level, analgesics would help. So similarly, any type of social reciprocity improving techniques would work. Any ways of improving the communication would work. Any ways of decreasing the stereotypic behaviors would work. But within that, there are also differences. Where how you might treat headache from meningitis is quite different from how you treat tension headache, both presenting as headache though. So if you look at the development in general, there are some things that would be the analgesics of brain development, or some things that promote and some things that would dampen it down. Biological susceptibility, which is from the genetic side or from perinatal insults. It may be to do with difficult temperament, poor home environment. It may be to do with poor stimulation. There are also things that you can do to promote, like good parental mental health and support, and reading to the child, and parental sensitivity, etc. And then we build it upon a population level program, which has to include universal primary health care, within which I would embed things like the universal developmental surveillance program and surveillance for autism. It's also very important to have high quality early childhood education. And again, the enormous benefit that can bring to the outcomes is really significant. And then you also have got targeted early detection, early intervention programs. So we are building at a population level certain things which is good for growth and development. On top of that, we have targeted approaches for specifically ASD children. This has been shown earlier, the Heckman curve, and I'm going to talk about it from a slightly different perspective. The return of investment is really greater if you do it much later. But how do we invest, and what's the impact? Yeah, at the individual level, there's no question lives of children and their families will be improved. But at the human capital, at the societal level, the lifetime cost of autism in pure autism is 1.4 million, and if it is also associated with intellectual disability and comorbidities, it is 2.4 million. And the Australian rates are 10 billion per annum, and the estimated cost for 2015 was 20 million, and now we have crossed way beyond that. And other than that, there's also the mental capital. On the cost side, on the return of investment curve that we saw, if you put training for adults, they would immediately go to work and give something back to the economy. So if you are in for just pure economic capital for today, yes, that's where you should be investing. I'm not saying that should be the only way, but that's where your predominant investment should be. But child intervention, particularly preschool age interventions, can produce massive savings, incredible amount of dividends, but you have to wait a very long time because we are talking here about social capital to reduce the inequity, and also the mental capital, the mental health and well-being of a nation. And if you have to really invest in order to get that, you can't go anywhere but in the preschool education and early development programs. Now, we do have data, but the problem is that the multiple sources of knowledge currently that informs practice are sitting in different silos. Education has got their own stats and costs and benefits. Health has got its own costs and benefits. Economic development has, and human services has too. But we do need to move on from there to get that integrated science of how early childhood development could drive all of these pieces of the puzzle, whether it's the health benefits, the education achievement of the nation, human capital, the economic development. So if we have got that as the centerpiece of our investment agenda, then again, we do need to have an integrated approach. We did talk about how all the time the different sectors are competing with one another, they are not talking to each other. We are really failing. We are failing ourselves, the society, and these particular children specifically. So it's really a policy idea to be taken from the stats and figures through the sourcing of the evidence, and then through using the evidence for introducing certain programs, interpreting them, and utilizing that knowledge. And once you are determined that that's the way to go, you consider the capacity to implement. And the capacity to implement should be looked at the individual level, at the organization level, and also at the systems and policy level. So I hope that this conference is about minding that gap between the knowledge that we have, the considerable amount of evidence that's already there about the benefits of early intervention, and then taking it into not only policies, but also implementing it into practice and pathways. Thank you.